Good morning and welcome to Global Healthcast, brought to you by Global Health Press. In this podcast series, once a week, we bring to you news and views about public health, infectious diseases, vaccines, and vaccination. I am Joe Schmitt, and with me is Dr. Melvin Sanicas. Good morning to Switzerland. Good morning, Melvin.
Good morning, Professor Schmidt. Good afternoon, good evening to those who are watching us or listening to us today.
The topics we cover today are chlamydia that settle in the intestine. We found new principle for treating tuberculosis, and obesity raises the risk for COVID infection by 1/3. I give you a brief epidemiology update around the globe and then an update on RSV and RSV prevention. But we start with chlamydia. Melvin, what is the story here?
Yes, so I chose this one because I think this is interesting to see that chlamydia can actually settle in the intestine. People who are infected with chlamydia can transmit these bacteria to other people during unprotected sex. We know that. And the pathogens usually cause no or only mild symptoms at first, such as itching in the vagina, the penis, anal region. And if the infection is noticed, it can be easily treated with antibiotics. And if it does not happen, the bacteria can cause serious problems, including infertility and cancer. And this study was actually done on mouse models. They have shown that chlamydia can persist in the intestines of animals and in humans too. The bacteria seem to make themselves at home in this place, and this was reported by researchers from the JMU in what is the full name of JMU again? It's a university in Würzburg,
Yeah, I
and
don't know the abbreviation. Yeah, it is
yes,
University of Würzburg. Yeah,
yes, Maximilian something, right?
yeah,
And
I don't know.
yes, and they identified the intestines as a niche with the help of artificial organs in miniature forms called organoids. And these are structures produced in the laboratory from human intestines that are very similar in structure and function to the model organ. And the teams from Würzburg and Berlin tried to infect the intestine organoids with chlamydia and then discovered that the inner cell layer of the organoids is very resistant to the bacteria. The pathogens could only penetrate there if the cell epithelium was damaged. And so the next step is actually for them to find out whether chlamydia can select certain types of cell for their persistence. And this is not easy, of course, but I think this is really interesting because it could potentially in the future explain why some people have chlamydia reinfection.
Yeah, very interesting research. I guess a pathogen we don't know too much about, and we're now looking for a disease, right? A disease of the GI tract caused by chlamydia. I trust people will continue to do biopsies for other purposes and then start looking for chlamydia. Very
Exactly.
interesting. Yeah, nice piece of research. And actually, you have another piece of research from Germany that is also very interesting. What is this?
Yes, this is also from Germany, and this is a research team headed by Professor Rainier Karlsruher from the Institute of Pharmaceutical Biology and Biotechnology at HHU, Heinrich Heine University, right, in
Very
Dusseldorf,
good.
and
Yeah.
Professor Dr. Marcus Kaiser from the Center of Medical Biotechnology at the University of Duisburg-Essen. And they have identified a fundamentally new approach involving sponge, marine sponges. Chemically, these natural substances of marine origin are classified as cyclopeptides, and they were able to synthesize new substances from these naturally occurring substances, and they in preclinical models show that they work against tuberculosis, and this has enabled them to produce these more potent derivatives that do not exist in nature. And these kinds of chemical synthesis needs to be successful before a potential active agent can be used as a drug on a large scale. So these are just preclinical studies in the laboratory, but these are interesting, I think, because at the moment we don't have really a lot of new drugs for tuberculosis.
Very interesting. So before we had a pathogen looking for disease, And here we have proteins from nature looking for therapeutic indications, right? And yeah, I'm not sure. How did they come up with using these substances for tuberculosis? Is this mentioned in the paper somewhere? I mean, I
Um,
would think of
yes,
anything but tuberculosis if I find a new protein in some sponges, right? I would think of everything. Why did they look for TB?
I think it's not really TB specific, but many researchers at the moment, because they're getting funding from TB agencies, right? So they have to look at the substances they have in their cupboard and see whether they work for TB, for HIV, for malaria. Well, because these are the pathogens that we get funding from the different agencies, right? So I think they start with that.
Yeah. So it's basically a big let's look what it's doing type of research. But this is really something, right? This is really exciting, and let's keep an eye on this for the future.
Hmm.
Obesity and COVID infection risk. We've mentioned that before, I believe, right?
Yes, we've mentioned this many times in the past. And this is interesting, although it's not new, right? I have to say that this is not new. We've heard about this for the past 4 or 5 years, and this paper just shows that obese patients exposed to SARS-CoV-2 are 34% more likely to be infected than their non-obese counterparts. And it really tells us that obesity is an important risk factor for COVID-19 infection and disease. This is a study of more than 72,000 patients at the Brigham and Women's Hospital in Boston. For this case control study, the researchers compared the susceptibility to infection of around 72,000 obese and non obese adult patients and pediatric patients as well, who tested positive for COVID 19 or reported exposure to the virus from March 2020 to January 2021. And during all the waves of the pandemic, obese patients were 34% more likely to develop COVID 19 than the healthy weight uh, peers, regardless of age, regardless of sex, or corrected logistic regression modeling, or correcting for all the different factors, right? So I think it's another study telling us that if you want to have a lower risk for COVID infection and COVID disease, lose weight.
Yeah, lose weight for various reasons, right? It is a risk for infection, but it is also a cardiac disease for, all types of other events as well. Yeah. Vessel
Yep,
diseases, right? Yeah.
exactly.
Thank you very much, Melvin. Very exciting. Your three papers, thanks for finding them. I have a little bit an update of outbreak news from the European Center for Disease Control. They're really pretty up to date if you check their website for outbreaks. They report that Mpox virus clade 1, I believe it is now found in Sweden and Thailand, and that comes from traveling to Africa. The total number of Mpox cases in Africa is now more than 18,000, and the case fatality rate is about 3%, which is substantial, right? This is really something to care about. Another piece of new information is dengue in mainland France. 10 locally acquired dengue cases reported from France. And you find the map on the ECDC website. Also, we do have West Nile virus in Europe and in the European Economic Area. And we have globally now, since 2003, 908 reported human cases of avian influenza AH5N1, and half of them died. So this is really something. I mean, you acquire the infection from birds or from poultry, and it's not a disease, or it's not an organism transmitted from human to human, as far as we know to date. And if you acquired it from a bird, half of these patients died. This is really something. And finally, polio. You probably heard in the news about the circulating vaccine-derived poliovirus 2 circulating in Gaza, and they started a vaccination campaign there with a at least partial ceasefire. And just as a reminder, to date in 2024, there were 27 wild poliovirus cases reported from Africa and from Afghanistan together. So this is roughly the situation around the globe, and I guess with this website and a couple of others more, we may once a month or even once a week update you, depending on what we find, to keep you posted on what's going on around the globe. Any questions, Melvin? I forgot to ask.
Not a question, just a comment, Professor, because I also have received these questions about the different clades of Mpox, right? I think this is an important information for public health response, for tracking epidemiologically what's out there. But for individuals, for people, right, it's important to just know that the treatment, the vaccine works for both clades, and the infection control procedures are also the same for both. So I guess my advice is just to really not um, care about which clade is
Yeah,
being transmitted, right,
yeah,
where you are, because
yeah.
it is very important for a public health from a public health perspective and from an epidemiology perspective, but not for individuals.
Not for your daily, for those who get sick. Yeah.
Exactly.
Thank you for the comment. And I want to speak again about RSV, and I would want to put it in a more global perspective on pathogens causing acute respiratory tract infections. Actually, we can classify them into, let's say, 4 different types of infection. And first of all, we have colonizing bacteria, and they are listed down here. The most important one and the most frequent one is Streptococcus pneumoniae, causing pneumococcal pneumonia. The others are less frequent by far, causing pneumonia, otitis media, sinusitis, whatever. And then we have Astreptococci, and these organisms cause strep throat or pharyngitis tonsillitis. These are there and they only cause rarely disease. 5% of adults and up to 50% of children under 5 years are colonized with the pneumococcus and they are not sick. So if you find them, we don't know what it means. And this is different with non-colonizing organisms. And among the bacteria, there are chlamydia, causing pneumonia, trachoma, genital infections, whatever, Legionella, Mycoplasma, and Bordetella, causing respiratory infection, including pneumonia or severe cough for 100 days in the case of Bordetella. Those you can treat with macrolides. So this is the difference between those and those. Beta-lactam, here macrolide antibiotics, colonizing, non-colonizing. Now we really get sick 6 times a year with one of the non-colonizing epidemic viruses. And the most important group here is rhinovirus, followed by these brown viruses, and then by the blue viruses, and then by the others. Now, why do we get sick again and again from these pathogens? For rhinovirus, the trick is there are more than 100 serotypes. You had a serotype infecting you today, you were sick for a couple of days, and you can get infected again with another serotype next week. So the explanation is too many serotypes. For RSV, parainfluenza, and human metapneumovirus, they are stable. They don't change their surface antigens too often. So once you are infected, you become immune and protected. The disadvantage and the trick of these organisms, the immunity that gives you protection only lasts for 6 to 12 months. And then you're susceptible again. So with the brown organisms here in brown letters, there it is our immune system which fails to give you good and long-term protection. Now then we have the blue organisms, SARS-CoV-2 and influenza. They change their surface proteins every couple of months, or in the case of influenza, every year to cause annual outbreaks. And for influenza, every 10 to 30 years, we have a major change in the surface proteins. And then you have a pandemic every 10 to 30 years. And the others I don't list here for other reasons. But this is the trick. Many serotypes, non-appropriate immunity, no stable and good immune, no protecting immunity, and then changing the surface. That is the groups of organisms that we have among the non-colonizers. And then just there are a couple of rare organisms causing acute respiratory tract infections or not so acute respiratory tract infections, but they are relevant for physicians for the differential diagnosis when a patient comes to their office. One very recent piece of information is, and I don't come into all the arguments, RSV, parainfluenza, and human metapneumovirus are the prerequisite for pneumococcal pneumonia. From the SARS corona epidemic, we know there was a year or two where RSV disappeared. And all of a sudden, pneumonia from the pneumococcus was gone. And then RSV, PIF, and human metapneumovirus came back, they returned, and all of a sudden, pneumococcal pneumonia was back. So we know today these organisms, they interfere with the pneumococcus in a way, and there are several hypotheses and several pathogenic mechanisms. So it is the prerequisite for pneumococcal pneumonia is infection first with these viruses that I listed here in brown letters. I think this is all that I wanted to say. Do you have any questions, Melvin, or any comments on this classification?
Not particularly a comment or a question, but I think it's just for us to remind our audience, right, that the reason why we are discussing this is actually it's important for them as well to know the difference between these non-colonizers and colonizers, because it has a lot of implication for not only surveillance but also for the treatment, for development of maybe vaccines or treatments for these organisms. And so this is, I think, more complicated than the previous slide when we talk about the clade 1 and clade 2. We don't really have to care much, right? So this one is very different.
Yeah, it is very different because different vaccines are to be developed, right? We have influenza vaccines, but we need annual shots because they change the surface and you don't know what it's going to be. So you have to develop something and it doesn't work well, right?
Yeah.
For RSV, you need a different vaccine. And actually, if I may go on, Melvin, here on this slide, I have summarized the recent developments for infants. There is now a long-acting monoclonal antibody, nirsevimab. It is a humanized monoclonal antibody produced in Chinese hamster ovarian cells by recombinant DNA technology, and it can prevent RSV, lower respiratory tract infection, in neonates in the first RSV season. And that's the indication. And it is given as 50 milligrams into the muscle if the child is less than 5 kilograms, or 100 milligrams if it is over 5 kilograms. And at least in Germany, the price for 50 and 100 milligram is the same, at least to what I found in the internet, right? So if you happen to have a heavy baby, you can still vaccinate it at the same cost as the not so heavy baby. And then there is for adult vaccination, or actually for vaccination in pregnancy, there is now a pre-fusion F active vaccination, and you vaccinate the mother. And vaccinating the mother then gives protection to the child for up to 6 months. And that happens through passive transfer of the antibodies through the placenta from the mother to the child. And then the child is protected for, again, up to 6 months. And both approaches are highly effective. It is not 100%, but they are both highly effective. In addition, this vaccine is also licensed for adults as of 60 years. In addition, there is a similar vaccine with an adjuvant called Arexvy that is also licensed for adults 60 plus. And then, as of very recently, at least in the United States, there is an mRNA vaccine, Mresvia by Moderna, and that is, again, an RNA-based vaccine that is indicated for vaccinating adults as of 60 years. So by today, we have 4 opportunities to protect against RSV for infants, that is what you see here, and also for older adults at high risk for RSV and RSV complications. Melvin, any questions on that?
Well, not a question, but just to highlight again to our audience, Professor, that imagine just look 4 years ago, right? We didn't have all these new treatments or tools against RSV, and it's a very different world now. And hopefully, in the next few years, we will be seeing real world evidence really to show that these tools, these new tools, are really reducing the burden of RSV.
Absolutely, yeah. And hopefully also of pneumonia. I got my 60 plus shot with one of the vaccines for older adults, 60 plus, right? And if needed, I would want to have that every year, right? As of age is a risk factor. And look, it would be stupid enough if I die of pneumococcal pneumonia, and if I can prevent it. Actually, I got my pneumococcal vaccine shot, but I also got the RSV shot now, right? So
Yeah.
let's see. I trust I won't die from pneumonia. Very good. I think that brings us to the close of our presentation today. We spoke about chlamydia settling in the intestine, principles for treating tuberculosis, 2 drugs found in sponges, obesity gives an increased risk for COVID infection. We updated you on Mpox with cases in Europe imported from Africa, 8,000 cases in Africa. We spoke about H5N1 cases since 2013 and the high case fatality rate, 50%. And then I gave you an update on RSV and about 2 out of the 4 vaccines that are licensed now in the Western world for prevention. And with that, we come, Melvin, to your cartoon of the week.
Yes, I think this is very self-explanatory. It's just showing us that we should not think that something is causing the other just because one thing happens after the other, right? So it's clearly shown in this cartoon that the dog thinks that he is hearing very well because he broke his leg, but obviously it's not because of that. And I think in real life, many people always go into hasty conclusions saying that this one thing causes the other just because one happened after the other, and we should just be careful in all these hasty generalizations.
Yeah. The old Romans 2000 years used to say post hoc is not propter hoc. If something happens after something else happened, it is not because there's a causal relationship in the end, right?
Exactly.
But very nice. I like this very much. I have to keep it for future presentations on side effects and adverse event reporting. Thank you very much and goodbye, and hope to see you again next week.
Thank you, everyone. Stay safe.